اينو شينا فرقت بابني انا يعني قابل نسوس كيتو هل فرجونا ميقرك على نحميخو اديوم استي فروسو لايف مو كونغرس دا SURYOYE دي بريثو WMAS اثمل كتو او فوتو حوبي عيتو دمور يحقب حزال خو 4 ساعات تقريبا 5 ساعات فروسو لايف تسملان ميتامو بو فوتو حسما تري مملي مي بروفيسور شابو طلاي و مي اوسيثو ميدن ملي علو في الحلو مدة سملة بوبو حنود علو كانسر على عملية وحد دوبع كي بيدور علي تحرستو دث من فارج على هركيك وحزيتو أبرجي لتنت بوبل أبرجي ستوكولم مي خسرايو مايو وحدوثة لستوكولم علو دربو علو أوتوبان كي بحوزي أبرجاني حاملنا يعدو لك محبي شمو بي خسرايو إفني ثاثة كولا تقريبا عمرتو علو أوتوبان حثتو
Men hör det inte en jag var ju
Mano, rápido, não falhou. Nej, men det blir så långt ifrån den här.
Förra året chefen, han var helt bra.
Jag har träffat en ny, han är nere i så.
Han var bra.
På Instagram.
No, never. It's
you.
Very nice. Is it okay to take a photo of you?
Ja, ja.
Show my grandchild that I'm making a way after this. Thank you.
فرجنا مياقي خدكو حزيتو أسي وأشام وعياضة يفك عنيك كوثن تقريبا هيدي كمانو وتعبيرو كامل وقبودن أترقومي ومملو يابو بوديوقو نحلة عيتونوي
اوكي قاعد كمينا خون طريق سفرو كلكم نافذوا بسلامة بوشينو بوشلومو وسوثو الحيمة حولنا ميقري ساقي سحينا موقع بوشمو ديماس World Medical Association of SURYOYE وحيو دو SURYOYE تبلوديو سيوثو دافوتو بهوخا مليون رابو حالنا محدودة أثمل السنة مفتوحو عم يشكي حوث المران فاتر ياخو فاليوم وساقي ديرانويو مفتحونو وباسيمو وميوم استقلوقا يقولوا رابو تحتوقو بيشان بسيديتو سريتو بس ببيث الكولا تبلوي ساقي سحينا وتودي عليهم دافوتو نشتو تدخل بولي مودو participants بشدارهم abstracts سلام برنامج ساقي شافيرو لليوم بولي مودو دنربو ديماس and give me to Stockholm. I welcome you from the very deep of my heart in the name of the World Medical Association of SURYOYE. We're really very happy to see such a big number of participants who have submitted their abstracts and presentations to come together to send a sign that we SURYOYE doctors and healthcare professionals are there, are in the world. We have to say something. to build up a strong network, but also give hope, not only to the SURYOYE doctors and healthcare professionals, but to the entire people of SURYOYE. I'm really very proud of all of you. You took your time to come here. And today we start the 4th Medical Congress by SURYOYE doctors, scientists, professors, researchers, and healthcare professionals. So please feel very heartily welcome to the 4th Medical Congress. Thank you for all of you for being here. Thanks a lot.
Drich Safro, ons mi adat baranto, ons de commander voor Shena Bashlo Mathitu, Kulekhu, Usiam Yakre, Haurone, ضيفه مسود وما تكون راحوا خير كل خبشينا بشلوما أثيتو خدوم دبروني دنو وسيوفوات مرلي وكتلان غلبة ترجوني غلبة كوبن حيلو وهو لي وتيوتو وبروغرامي دا غلبة عطيرويو بس هم ستوزر نيزنستي كوب موقع عيقويو موقع كتلان نشمو instructions الكم كل ترجمة 8 دقائق 8 minutes with 2 minutes for discussion. كبينا كل إخوة بالخيط وعلو زرناو لقنا قدرينا مخلصين ويا ميزان عاصيمة وجوزر نيزة عم كتلان قالة عصرية محقين عليه. As an moderators على قدرات ندير في هكى سامي برسنتيرا عن الكوب المملو أو سيد بدوب المملكة وملخي عد دخلنا ملخينا علوزة نيدا بصر قدوة خد ملي إيش مزبنا لشوالي بصر معي وستي خد خزيتو كتلانو بروغرام كله وبلكي حزالكم بس غلبة مهمة والصويد ملخينا علوزة منو ومي دحرينو كتلان certificates كل حد سنة ريسترير عروح لو كنيشيو لو مودانو كتلر سيرتيفيكتس تعمل أربعة كل حمل خود ميليتو وورقات خود بيلد مالخو بلكي لو شغله أو لو كارير أتوالي تبلك حسابه كل الأربعة هيك على الصدر حد ينوفق على الأربعة وكمان أنا مدحرين ولا تنا instructions له بس وزبنا مهميو توديوت غلبة لو حورو عبد المسيح غدالد أخيلا أولي موسيقى الرحيمو وتولي لفت فرص حزب استقلال هكي محول ولو مدانو دا ديوما بميلاني مشمعين أخو ولو مدان دان أربعة كتير مكتب زرنو هكي بسويت فتيقو أنا قاعدين كتلان keynote lectures عودوا معزونا وسيو يامو دنيس آتيقول مع أمريكا لكن دو حوض بينوتينا دو بيلان ترجمة بس قاميتو هي so introduce the next speaker before you will speak. Okay. وسيو يامو دنيس New York City.
Sagi. Afino l'erche urbano tre masai. Ha dico qudano mjgano busrio l'osie wasio SURYOYE actually a dream khatkamni to one day do it so adioma qudano domano todi galabi l'osio Ormanu President WMAS given this opportunity. I really appreciate it. One of my dreams has finally been fulfilled, to speak to my own people. Ufua. I want to welcome a dear friend of mine. In 2000, I was a very junior faculty here at the Karolinska. I had finished my training at Duke University in the US and had the fortune to come back as a visiting a scholar and worked with Gunilla Hedlin, who was my mentor, along with Anders Lindfors, and then over the years I got to know Sven-Erik. You all have seen his bio sketch, so I'm not going to get into detail. But as we think about our own organization, we wanted us to really to look at what constitutes a successful legacy for all the work we have done, and I will delve into it. Sven-Erik is going to talk to, having served on some of the committees of Nobel Prize in medicine, chemistry, etc. here at the COE. He's going to talk to you about what it takes and what are the requirements to win that Nobel Prize. And I hope that one day, and that's going to be the discussion among others that I will be having with you today. So without any further ado, Sven-Erik, I'll hand it to you.
The first one. So, thank you so much, Jarmo, Mr. President, dear colleagues, dear friends. It's really an honor for me to be invited to present to you at these difficult times. My former president here, Olle Ottersen, was very much involved in global health and worked together. He was Norwegian with the embassy of crisis, I don't remember his name, at UN, this Norwegian person. And isn't it working? No? You hear me now?
No, it's better.
So you missed my beginning. So I said it's an honor to be able to present here to the Syrian diaspora, and you have our empathy for all the difficult situation that sometimes is not getting enough attention. And I hope that the power of your organization and the things you do can help us forward. So I was asked by Jarmo. I should mention something about Jarmo. You heard very briefly he mentioned about himself, but what you don't know is that he's a member of CIA. But it's not the CIA that you think about. It's Collegium Internationale Allergologicum. That is a club for the world leading researchers in the allergy field. It's a club where you are elected, and there's only 250 members, period. So you have to wait that people die and so on until new members can come in. But I think last year or the year before you were introduced as a new member on your merits as a researcher in the field. He's run a lot of important clinical trials. Anyway, so how to get the Nobel Prize? That's the question a lot of people ask. And in order to present that, which I will do in a short while, you really have to start with Alfred Nobel. I mean, how did all this start? Alfred Nobel was a very unique person. He was a globetrotter before that word perhaps had been coined. Chemist, inventor, entrepreneur, misanthropist, and a very idealistic person. He was born in Stockholm, but his family was also very cosmopolitan, and they lived for long time in St. Petersburg, which, as you know, at that time in the 19th century was a very strong intellectual and business metropole. He never went to an ordinary school. He had a lot of private teachers. I think he spoke something like 7 or 8 languages, and he very early did very advanced maths and physics and things like that. The family did explosives, but nitroglycerin was, as you know, extremely difficult to deal with, and a lot of people that tried to industrialize the use of nitroglycerin perished in those efforts. But what Alfred Nobel did was that he learned that the package, how you put nitroglycerin into this sheet, that forms dynamite, then you can use it in a safer way. And he took patent on that. He established factories all over the world. He continued to do other things, but this made him, at the end of the 19th century, something like Bill Gates or something like that. He was probably one of the richest men in the world. He kept traveling all the time. He had no family. He lived at many different places towards the end of his life in Italy, in San Remo. He also wrote poetry in plays, and he was a very dedicated pacifist. So when he died, his will was opened, and to the disappointment of his relatives, he had donated all his money to a prize that should be selected in 5 areas every year. And you can see here maybe in yellow. So in the original will it says the prize should go to those who during the preceding year shall have conferred the greatest benefit on mankind. And the prize should be awarded, and we'll come back to this, for the discovery or invention within the field of physics, chemical discovery or improvement, and discovery in the domain of physiology or medicine. It actually took from his death 5 years until the first Nobel Prize was awarded in 1901. I mean, as you can imagine, first they had to find all his fortune and organize that. And then, as I alluded to, the family didn't like this. They wanted the money, of course. So there were lawsuits, etc. Even the Karolinska Institute, that was supposed to select the prize in physiology or medicine, were reluctant. Should we really do this? But then the solicitor Ragnar Solman, who arranged this, included the professor of physiology in the process, and it must not be an issue. It must not be an issue when the prizes are awarded, because he was a cosmopolitan. Literature and peace, and I mean you have selected literature and peace, and I mean you have selected a really good time to have your conference, because now all the basic prizes have been awarded, and I would gather that Nobel would been particularly pleased with yesterday's Peace Prize, which in my opinion was really a very, very, very good selection. What you should know is that the scientific prizes are awarded for discoveries. So there's a lot of eminent good scientists that deserve lifetime achievement award for their what they do, but they will never get the Nobel Prize, because the Nobel Prize should be awarded for particular discoveries. And that's actually also why this criteria of in the past year, as is mentioned in the will, has sort of been neglected, because, as you know, it takes time until you know what is really breakthrough discoveries. I mean, look at the AI prize earlier this week, and the micro RNA prize. You know, that took time until you understood how important it was. Another restriction is that only 3 persons can share the prize. So, I mean, I can say very specifically that in our field, the discovery of IgE is really worthy a Nobel Prize. It's a diagnostic, it's used as treatment, anti-IgE, etc., and it has been extremely important. And it was a very nice basic discovery. But the investigation we made showed very clearly that it was 5 groups that did everything at the same time, and it would be unfair to give it to 3 only of that 5. So that prize will never happen. You can give the Paris Prize, as you know, to organizations such as yesterday. You can no longer, it happened once with this cancer prize, that the laureate before 10th of December, when the award ceremony is, 10th of December is the death day of Alfred Nobel. But nowadays no posthumous prizes are awarded. So the first Nobel Prizes in 1901, I think, really assembles a list that most of them you remember. Röntgen, of course, those of you that know your chemistry also know Van Hoff, Emil von Behring. Literature, Sally Prudhomme is probably not so much known any longer. It has been rumored that she at one time had a relation with Alfred Nobel. And I don't know if that influenced the committee at that time. And this was the first time the Red Cross got the prize, very appropriately. They got it 2 more times. So the awarding institutions are the Royal Swedish Academy of Sciences for Physics and Chemistry, the Nobel Assembly of the Karolinska Institute in Physiology and Medicine, and the assembly actually sits in that building on the other side of the road. The red brick building there is the Nobel Forum. The Swedish Academy, the Literature Prize, and the Norwegian Nobel Committee, the Peace Prize. As you may not know, around the turn of the past century, until 1905, there was a union between Sweden and Norway, so therefore it was a joint effort. There is a prize that will be announced on Monday in economic science. That was a donation from the Swedish Central Bank that started much more recently. So it's not really an original Nobel Prize, but it has more or less the same status now. There has been lobbying for additional Nobel Prizes, like in environmental science, etc. But I don't think that will happen. Would probably dilute the prize. Physiology or medicine, I already mentioned. I think physiology is for the basic part, and medicine is usually more clinical. But there's no, I mean, as you know, in this society, top class research is translational nowadays, so that's not a big distinction. But one could maybe say that last year's prize was more medicine with micro RNA-based vaccines, and this year's prize is more basic, more physiological, so to say, on the micro RNAs. So the Nobel Assembly, as I said, sits in that room, and there is a selection of 50 professors at the Karolinska Institute that are members of the Nobel Committee in a rotational matter. Then the core of the work is done by the Nobel Committee, which have 5 ordinary members and 10 adjunct members, and then that is the driving force in preparing the proposals for every year. But then the secretary that sits in the office I pointed at is very important, and the whole administration. And there are archives in that building that are almost as difficult to get into as a bank, in the old days. And everything is under embargo for 50 years. So most of us will never learn about the reasons behind. So, for example, there has now been a film and a debate about the Nobel Prize in Literature for 1974 because the archives became public. And that was, as some of you may have known, quite a tragic situation. It was two members of the Swedish Nobel Committee, Harry Martinson and Eivind Johnson, who got the prize. And people thought it was conflict of interest. They were not, at that very leftist period in European and Swedish history, completely accepted by people. So it went so bad, so Harry Martinson committed harakiri, suicide, at the hospital here, and died in February after the prize. Very, very tragic. Anyway, I should move on. So the cycle is like this. People can nominate, all professors at Karolinska, many institutions, universities all over the world have the right to nominate. You cannot not nominate yourself. If you nominate yourself, you're out. And then the committee, the administration brought some of these proposals. I mean, there's obviously good things come back and mature. I mean, people that get the prize may have been nominated 10 years ago, and then they are evaluated, and you move up on the short list. And then during the summer, reports are written, and when these reports and the scrutiny is done, very often the committee uses external advisors. So, for example, there have been some prizes close to my field, and then I have been under confidentiality, helping with the review and preparing background, etc., for the committee members. And then the first week of October, the prize winners are finally selected. Often it's one proposal. At some occasions there have been two. And then it's voted, and then the door opens at Nobel Forum, and the prize is presented. And someone, often in America, when it comes to medicine, is woken up early in the morning. There are I am just with some historical things. There are a few that have got more than one prize. Marie Curie. Linus Pauling, I think, is particular. I mean, first he got it for chemical bonding, bonds details, but then he got the Peace Prize for exactly the same reason as the Peace Prize yesterday. He was a driver in anti-nuclear war, so that's a very, very, I think. And someone like, Sanger, the Sanger Institute now in London. So very, very prominent people. There are some families that, have got the prize, where it has father and son. Hans von Euler-Chaplin, for example, got the prize in chemistry. And actually on one of his papers, his son Ulf von Euler and then Ulf von Euler got the prize for demonstrating that noradrenaline was the transmitter in the autonomic sympathetic nervous system. Ulf von Euler was a remarkable person because he also discovered prostaglandins and substance P, other prizes. Sune Bergström, together with Bengt Samuelsson and John Wayne, got the prize for prostaglandins and leukotrienes. And Sune Bergström's son, Svante Pääbo, was the one who got the prize for the DNA use to study Neanderthals and all the origin of mankind. But he was actually the son of Sune, although it was not known until after Sune's death. Sune was quite well to do because he had developed the prostaglandins for use in both labor and abortions in the third world. So when Sune got the Nobel Prize, he donated about half of it to build the fountain you see in front of Nobel Forum. So that's a very expensive fountain made by a sculpture person, and that was Sune's donation. Interesting to know. So why is it so prestigious, finally, the Nobel Prize? I think it's because it's so old. And it's sizable. Now the Lasker Award, I think, is more money-wise, and it's also very prestigious. But it covers these broad areas, and what I really think it's an extremely careful selection process and a very stable organization, and with occasional few mistakes. The majority of the selections have been very good and have really been finding the right persons. And I mean, you can just look at this list of names: Curie, Planck, Einstein, Bohr, Röntgen, Camille, O'Neill, Hemingway, Red Cross, Hammarskjöld, Martin Luther King, Fleming, Florey, Banting, Watson, Crick, Jacob and Monod. I mean, everything is in the history book of the particular fields. It's a grandiose ceremony when the prize is distributed, and it's a great party afterwards. And if you want to learn more about the Nobel Prize, it's quite interesting. I mean, I use it often when I am going to give lectures about some historical thing, to go into there, and then you can read about what the awardees have done and so forth. So, thank you.
Tack så mycket för en givande föreläsning. Där får du en Nobelpris.
SURYOYE Nobel Prize.
Thank you.
Now? What? Okay, perfect. Sven-Erik, I honestly believe, so 1967, you mentioned the IgE discovery by S.G.O. Johansen, who is a very preeminent professor here, and also Ichi Saga. I always said if he had not been a Swede, he probably would have gotten the Nobel Prize. The Swedes are very, very meticulous and very critical of their own, and probably that too contributes to why the Nobel Prize is so incredibly selective and so on, but that's for another day. Fuad board members, I am really grateful. And I'm going to start with the end in mind. When we walk out of here, I don't want you to remember anything. You'll learn a lot of science. That goes without saying, and that's my element as well. But when we were talking, and I'm very grateful for it, to the president, he gave me two options, either to talk about what I'm spending my day on, dupilumab and type 2 inflammatory diseases, or let's see what else we can think about to actually reflect back 24 years from now, 26 years from now, and ask ourselves the question, have we done our job correctly? And so, how do we measure that? Is it going to be research papers? Probably. But there are many research papers that are going to come out there. I think for people, such as our people, who grew up in the diaspora, who were given the privileges and the fortune of living in a country like Sweden. I grew up here, by the way, not very far at Kista, went to Spånga Gymnasium, and then I went to Sweden to capitalize on the unbelievable education I was fortunate to get in this country. So as I get into my slides, I'm just going to ask a few questions, and hopefully it will all come together to all of you. And I am wary of my time, Fuad. So if I'm not, yeah. So how many of you were born in the diaspora? Meaning Germany, how many? Show of hands. Okay. And then how many of you are the first to graduate from university? Not medical school, not dental school, but university. First in the family. Less number. And then when we think about our own kids, how many of them are actually bound to go to college, university? Much larger number, as it should be. So how do we capitalize on this? Actually, before I go there, how many of you have parents who are either high school or university graduates? Few. I'll be the one to say, my parents are analphabet. They don't even know how to read and write. And I believe that many of you, show of hands, yeah, have gone through the same. So if two illiterate parents like me, who had to leave Turabdin, Midyat, which is where I was born, and I'm very proud of it, and that heritage is very important to me and who I am, were able to imbue in me the values of education to allow me to get to where I am because of the opportunities that a country like Sweden or Fuat, Germany, Netherlands, all of these countries invested in illiterate immigrants to come and gave them and their children a future. So reflect on that now with all of our cumulative education, our abilities and the networking that we have. We have somebody who has served on the Nobel Prize committee come and talk to us today. That's the level of networking that we now take advantage of or should capitalize on. By the way, I wasn't going to talk about CIA, but thank you for mentioning that. If we are able to get to where we are, now move forward till 2050, and that's a number we just picked out of thin air, to be honest. Imagine what we need to do, or if we were to do it right, would we actually see a name, a SURYOYE or SURYATO? My preference, and I believe it's going to be a SURYATO who gets a Nobel Prize first on that list, so that when Sven Erik's grandchildren come and talk about how to win the Nobel Prize, there will be a SURYOYE or SURYATO who actually was born in the diaspora. So when you walk out of here and during the discussion, and we will see a lot of science here, I want you to think about what is going to be my role to actually mentor, to groom, to bring somebody that actually advances the sciences. And if it ends up earning them a Nobel Prize, I'll probably be the happiest man on earth. But if it doesn't, that journey itself, I believe, will have then done justice to the opportunities our illiterate parents were given by countries like Sweden or any of the European countries, that their descendants served society and then served humanity. So that should be the measure and the legacy of WMAS as we think about our involvement, as we think about our contributions to the organization, and then importantly, to our own community and the countries that now have become our home countries. And I urge you to always aim high. Aim high not just with what paper you're going to write, but where that next talent is. And this is why Fuad and the board were very meticulous about inviting students to actually be part not only of the organization, but also get the forum to talk about what WMAS is. And that's what I want us to all walk away with. So with that, I'm going to just show a few slides, and then I'll hand back the time. I hope I'm within my time. By the way, this is part of my plan to see if you can be patient. I'm just joking. You can see it all. Perfect. Another Nobel Prize winner. So given what I just shared with you about what is expected of us as physicians, as healthcare providers, in our specialties, we know that this future is actually in our hands. And I think the blueprint of WMAS gives us a good ground on how we actually can capitalize on it. So Richard Feynman was a physicist, and he was also awarded the Nobel Prize, but I usually go back to him because the way he talked about quantum mechanics and quantum computing. But he also was an incredible teacher and very selective at Caltech at really grooming and developing people. But he said the surest way to predict the future is to invent it. We have all the resources, all the capabilities. If we want to only invent that future for our people and for humanity. Originally, I guess I missed a few slides, that's okay. Originally, I also was going to show you a little bit about type 2 inflammatory diseases, but I'm going to skip it in the interest of time. When you reflect on today's data, think about how does this apply to me? Think about what am I walking away with? And to the younger students, think about how can I find a central role to play? How can I also build the courage? You have an amazing opportunity for the younger physicians in this room today. Network, capitalize on this networking, and then ask, how can I actually build this journey that is going to contribute to hopefully by 2050, we can talk about one of our own who has earned and who has contributed to humanity in such a manner that she, and I believe that she or he, will be able to, with pride, reflect back and say, in 2024, right across from Nobel Forum at the Karolinska, there was a discussion, and this committee had the foresight to say, we're going to put all of our energy to also groom and develop this next generation of scientists, physicians, dentists, healthcare providers. Last but not least, my mom asked me, are you going to talk in SURYOYE? So شبكونا ما هاجر شمعتلي ما SURYOYE دي لاتيو غلبة قويو خدامنا ومشغلنا بليشونو تكتيو غلبة قويو دمانو ميدت كبعنا دمانو بلي إيمي هاثي ميدايرويو محتولي أوسيو إلو كدانو شاتو حريتو تامو بسيمينا لابوتر عبدين, and I really look forward to it. ليلة شيثو تشعيش نيسو هي يدخولا energy لنو. I am sure many of your moms and dads have done the same for you. So Todi Sagi for the opportunity.
Todi Sagi, very nice speech, Dr. Yamo.
Congratulations. Well deserved.
Be in the centre at the same time as like loving people. I can't get this into one.
He was probably a bit bipolar.
Oh, really?
Yeah.
Is that what they
Yes.
Oh, really?
Yeah. Most of the time very hyper, but sometimes he
went into depression.
He had hope, that dynamite would be good, and then it was used, as you know, in the wars.
Yeah, sure.
And then he felt guilty, so to say.
So we're looking forward to the next session, which will be the first session, of course. So my name is Christian Sanderson, and this is my the main chair, Professor Adalberto.
Does it work? I don't know.
Maybe you can put it closer to your mouth. So we're looking forward to the session. Let me tell you a couple things, just to tease your mind. I've been for 3 years voting for Demis Hassabis getting the Nobel Prize as my full professor, and it's the first time we have big tech getting Nobel Prizes. Google is getting Nobel Prizes. Humans won't get Nobel Prizes in the future on AI. It will be the last inventions for humankind. After that, it will only be ASI. I'm going to tell them a little bit about it.
So, holding Professor Christian Samuelsson for that introduction. And I'll go dinner with the best part, orthopedic surgery. So,
تمام شغل.
So, حكينا نحكوا اسمه على orthopedic spine surgery and endoscopic surgery. فيو مهمة و اسمه يلفينا أيدر بكم على خو شغل عمينا. ما لخلانه. خذيتو قايكو بعمل محوينا نحكوا اسمه محكينا نحكوا على جرح دو حاصم. على هانو تكنيك حاصو بلاتي بالكي غلبة حاطة محوين الفوس دايش مو مكتب دا نيدي بس خذيتو غلبة شافيرو بغلبة ديتايل و مانيفاكتشن كوحودينا وإلى الكوزيمينا عملية دو حاطو يعني how to get to the spine with a camera to perform the surgery. قايو هانو الطويو عند حزينة غلبة بحر شافيرو خريحو وهم مديتل وهم ستي إن قد قيسين على با تكنيكات حريني إن قد كفوتك وقلدو شو متواردة جارح مسكولر أمدوني كوب زرالو برنوشو موقعو تكنيك مطور وهانو كتيو وحاثو قدرين سيمينا عملية دو حاثو عن كوزيتو تانو شبو حد قد مستعمل مايكروسكوب بس ويدك حد سوم عملية غلب عيفو حالك كوزي أخص راوت ده تبدأ إنك أحد كفوتك كوزيتو كوي غلب جرح ولو بشمو موقع كوبز ستي يشمو ريسكر موقع جلوزن ميدي حاطو توتر موقع تكنيك دي كاميرا مطورو بس كوزيتو لاتيو ميدي غلب حاطو بس ومكتب دمنيدي حاطو يو ومكتب دمنيدي حاطو يو عتيقو يو بس مطور جلوزمنا مطورونو زوقيو عالد كو سيمينا عمليات على واردة on nerves and spinal cord موقع دي قريش لزبنو هود مطور فلو مدد كيتو عدد مستعملين عليه عزيتو هيش مشروعيات بديلو تكنيك بصر مطورو كل عصرو شني وهاي مطورونو بو تكنيك بس هول تري ألفو دو تكنيك عدد مستعملين عليه نافق من بروفيسور سباستيان روتن كت يومين مديتا دو بروفيسور متي شنكال بهرني وأونس تتعامل يعرف نو تكنيك وعدو كما وزعين عليه بسويت خزيت وأنا قا بديلا بوحاصو على اللومر سباين وعدو هاوي تكنيك تقدرين سيمين عامل استي بوقدولو بوحاصو دو سطرو هاي هو تكنيكانو طويو عاد كتلا results ومدك سيمينا لغلبية طويو وتكنيك مستعملينه للمطور قدرنا سمينا بمادة شافيرو دلو ريسك لوكايو وللجرحين أصلي دمينا أو مسكولار أنر أميدوني بصر الريسك دمينا عملت كنا قد عكسمينا عملية كيتو ريسكاتي وريسك رافو انفكشنز يعني انتهاب كوفيد دو جرحو هانو لتلي ريسك دو انفكشن موقع حما بنفيتس كيتو وتكنيكانو وحرينو خايفو وكايو قلنو يحلي خايفو قدر دزيو لو شغلو لميدوني هوخا وخايفو استي دمينا لقلوز فوش بيقصنا خانا دوعر لفلحوني لميدوني وهانو استي كوي تكنيك كتيو رح يستر لقصنا خانات لي مجتمعه ما خو تكنيكانو كوي الترناتيف لا تكنيك عتيقة كيتو خزيتو وجرحو دو قلدو بس هوخا نعيمو نعم ترمي سنتيم وبرنشك سمينا لعملياتي من فايدة كتلة ماني اخذ خزيتو لكويو على الجرح ونعيمويو يعني حبايت نورمال عادي بدون هوخا باراسيتامول مكفي وجرحو غلبة نعيمويو لو بس لو قلدو إنا قد كوزانوستي دمينا وقاوي دو بشمو لكو جرحو رابو وخايفو مقدمة لجنوية ليتو ريسكس وكوفيد داي سيرجري يعني وكايو كوزيو لو بيتو بصر 4 ساعات ما خلصنا عملية وريهابيليتيشن خايفويو وخايفو حق دور لو شغله وخايفو استدمينا وحط دور لا physical activities وعبرنا شو كله قدرنا سمينا بس كيتو one indication كيتو توتل إن حتى تشيك حقينه بكيلوات خد بالي قدرنا سمينا وحاصل كله وتكنيكانو بكاميرا وأكيد وحاصل كله كتولي تانو أغلب من ولد قدرنا رعدو مطورين أو تكنيك سمينا spinal fusions يعني محتينا بريغي بصرينا وحاطو بحدوده وتكنيك رعدو معطينا التامو بس لكي بس كوسمينا لك combine with navigation يعني نقا قدرينا محوينا وبصر صرتو يدربو هانو رعدو endoscopic surgery يعني بكاميرا وهم مستعملين تكنيك حاطو دون navigation قدرينا حوزينا وبريغي نقا محتينا بوغرمو حوزينا عليه غلبة ديتايل وعوبر لو غرمو ولو جارح لو باريده ولو متحرينو وحوزيتو ليه محدين لو بريغي وهاو خاصة دمينا وقرمو تشيكا جرحين على دقنا بنو يخضوو وحوزيتو جرحي دو قشنو بس لوتو نقويني وهاثي ونقع قاميته عملي قاميته احنا بسملا بريتو كولا هيش نو شخر نلسن نهانو سملا combine navigation with endoscopic surgery محكينا نقمت له حامة كيوت لو حاصل قدرنا سيمينا بتكديكانو هانو كميلة disc herniation spinal disc herniation أو فتقو دو حاصل موحي بواردة قاعدتو بامو حمشو مع معامل قويت لفتقه وعمره قويت لبان حضر 40 ولا تحمو حاطو ويدكسو كتيو أغلب حاط قويت ليه من كيو حاك قويت لنا قد كتلة ديسك هرنيشن أو فتقون يا كيو يدو حاطو كيو استد موحي برغلي على كو جورح أبو عريدو قد قاضيتو موحي برغلو كوتونت يعني نامنس loss of sensation ونقاوس لإيقوة دو رغلو دمينا كونوكس وحال قدر يوتو إنا قد دعينا قيو وبرنشان كتلة وكيو كوسيمينا MRI ماغنيت كاميرا وخوزينا أي دربويو وفتقون بيك ديتايل خوزينا لي وإنا قد لونو يقدرنا سيمينا نسب غلبة لوريس إذا قد كتيو خوزينا لي بمومو التريتمنت يعني من قدرنا معونينا وكايو يبي قاميتو دمينا حباي دون قوروني physical therapy أو exercise دقنا حد منقص أو كيو دو برنوشو ولات يوميدا تهليكا دمينا أو فتقو بعد خوزيتو بمو تشعي بو عامو كونو يحلي بين ثلاثة يحي وهاني لقنا يحي كوزنة اللي عملية خزيتو غلبة إشموني وعملت سمينة خزيتو غلبة بديتها خزينة أواردو دو سنر نيرف ستراكشر خزيتو لتامويو وأوارد دو أدموسك خزيتو ليان غلبة شافيرو خزينة لي وتامو للتحميني كزر كتي عوقا كمتو تامو وفتقود مدلميني بس كبار محوينو كوي على إيصرتو أي دربو أي دربو كزي عما كايواني ديدان إنا أكسيمينا العملية خزيتو و إيكيوان وصرتو قامير فيلد كمينالي عملية دي كاميراي وحرينو كتلن ريجستري سباينال ريجستري بسويت أكاي كل أكسيمينا عملية محتينا لتامو موقع قدرين عميدينا ريسلتس أي دربو كزي عملية إن قسمينا لقسينا محدودة فيلد وسباينال from spinal registry خزيتو يعني قد حدود إني جنويحي أكابيت قسمينا عملية يعني كون توتر وهنا عملنا نستدمينا لكون توتر إقدم شاليتو قايولو هانو كيتو غلبة السبابة دمينا بعطيري غلبة لا تندمينا جابوسيو أو نعطيري غلبة بصيرة دي عملية خد كديتو وكتلان بسوي قطر ورابو وهانو كل اسمنا الابليكيشنز هنا قد بدينا بو بعملية و اسمنا الابليكيشن على تكنيك حاطط كتب بسوي قضيتو هيش اي دربو اكاي راضيين او لاتنا راضيين و بينا قد قيسين عليه عن عمود عملية كسامينا لفتيقة مينا وعملية كتيو ستاندر بدولة وخزيتو هانوس عينيو يعني أكاي ويدن جنويحي راضيين مي عملية كتيو دي كاميرا لوحاتو وما حكيتو هذا ميتال أناليسيس هنا قد حق حوير بو ميدت كثير على تكنيكان وحاطو خزينة يعني هانو توتريو مو تكنيك كتيو عاتيكو أو كتيو نورمال كون استعملينا بدولة كلها بقصة كانت كل كتنة مايكرو سيرجري مايكروسكوبيك سيرجري يعني بمدن كل قيسينا له وتكنيك دي كاميرا توتريو وما خاصتي كاتب دي مقالة مرلي هانو لازم دوي جولد ستاندرد يعني عملية كل كايو لازم قدمين عليه دوبين عليه we have to offer endoscopic spine surgery for every patients that have herniated discs. تو دي ساقي لي شو مفهوم.
Yeah, that was great, actually. I will not do that as quick as you. I'm trying to be quick, though. So I forgot to, of course, introduce Professor Albaranto. He's my colleague. We work at the same clinic. Is a professor at our academy, and one of the best surgeons I ever had the pleasure to do surgery with. And if I have a back pain, I will choose him, not because he's Syriac like I am, because he's just simply the best I've seen, actually. So it's a pleasure to see that. So I'm going to talk a little bit about AI. Is it?
وبروفيسور كريستيان سوميلسون وانه هي حوروننا كوشونن عيدني استخانه سالغرينسكا بيونيفرسيتي سالغرينسكا وكريستيان حاما كاشيرت كتيو بو فرعيده لعمل دو بركم وهمستي بو ساينس كمان ليت كاشير درمينه بسويت كولا كتله هولو زدنا ماثو حمشيل مقاله scientific publications.
Okay, so let's talk about the future because it's here today, even though you might think it's not. So I have some closures. Why is an orthopedic surgeon sitting here or standing in this case talking to you about AI? I'm actually a computer engineer as well. Until I was 25, I was head of development in one of the biggest IT firms in Sweden before I changed career paths and thought this was fun. I'm also in the industry. I work with Cardiology AB, which is the second richest person in Sweden, and all these companies in 6 years. I focus on this topic only since 6 years only. So what is AI? What we do know about AI today is narrow AI. It's very thin within some border, like ChatGPT, can give you answers, it can communicate with you and so on, but it's not widely applicable. It won't change the tires in your car. But in the future, we're working against something called general AI. It's more of a human kind of AI, and it could go to new fields without human intervention. So what is that? Well, and when will we have it? Well, probably between 2030 and 2031. Why am I so specific? Well, Sam Altman, the CEO of ChatGPT and OpenAI, said 2 weeks ago, we already knew that they are already in stage 2. Stage 2 is an arbitrary number they created. They have 5 stages. And the 5th stage is AGI, completely automized AI. And they say it takes them 2 years for every stage. So we have AGI in 2030 with that performance we're doing right now. Superhuman AI is a conceptual thing. It's something that is as intelligent as the complete human mankind in total combined and knows everything. So we're not there yet, but it's a conceptual thing. And people think that if we have AGI, we will create ASI as well. And that will be the final human invention. No one will ever invent something after that. But if you look at narrow AI, it's quite stupid as well. We always said that, it doesn't know how to lift an egg. That was 2016. And we have these egg lifting robots by then. That's a, computer engineering comment, it can't lift an egg. And then Tesla's Optimus came along. In just a couple of months, they lifted up an egg, gave it to the other hand and put it down. The problem with robots before that, you had to teach them everything. You had to program everything. You had to make a digital twin of that egg. But now, why can't they do that like that? AI. They're unsupervised learning. So they use AI to teach robots. That's why we will see robots in increasing rates. But we are not, that's not what we work in right now at least. We work in physicians or dentistry and so on. What can we do? Well, imaging registries is one of the lowest hanging fruits because it's a painful task, something you have to do. It's cumbersome, you have to look through it. It's actually not human to be good at it. You have to be a little bit more of an Asperger or even autistic to even like it. So why would we do that? Because it's not human-like, effort to do so. Well, we have AI, it can do so. It can actually go through, like in this case, it went through metadata and categorized and functionally looked at pictures, and it did 800,000 radiographs in less than 8 hours, and then 99% accuracy. They redid with the 1%, and they had like 99.99 and so on. You can just redo it until it's perfect. You can do that incomplete really, really quick. So imaging is going all the way there, but it's not only imaging in descriptive and categorizing imaging, it's also creative things. So you can actually create pictures. I can create pictures, pelvic pictures, that I can use to teach AI. So generative AI is not necessarily something cool that is just a picture, it's actually medical generative AI. So in this case, what they did, they used something called GAN networks to create pelvic AI. So you can do it like a fat person, small person, male, female, and so on. It generates those AI pictures. And then with those pictures, you can utilize it in studies and it can teach AI. But we look at AI and we look at this picture and we think, or this video actually, and you think, oh, this is actually not human. This is generative AI. It's actually just AI generated. SURYOYE by OpenAI came in the spring this year. How does this affect anything? Well, everything. In 2 years, Midjourney came in 2 years, photographs are dead. You don't need to do any photographs. You can just do AI photographs. It's cheaper, it's much easier. Now video is dead. I can do a commercial on you, on the digital avatar from your social media that is perfectly fitted for you. You can watch a Lord of the Rings in 3 hours with your favorite actors in Wes Craven director style. Just tell the AI to do it for you. So everything will change with that. But we can also use AI in understanding new patterns. We can do that, for instance, in cardiology, left ventricle heart morphology, but we can also do that in skeletal imaging and skeletal injuries and registries and so on. So you can use AI to take a look, hey, what are we missing here on these registries, in these data? It doesn't really matter in what area, but we're finding more and more things that we've been missing for a long time. Where will we go, in our entities? Well, we're going to see more and more of digital twin technologies. A digital twin is a digital replica of a physical entity. So it's you as a digital person. It was created by NASA to simulate stuff in space before they actually send stuff in space. But when you can do that, it's the home of the multimodalities data. So your pictures, your lab, and everything will actually be created as a digital twin. So the journals in the future will not be textual based. It will be a digital twin of you. And you can do that with so many things. They use it, of course, in cars, in so on, but we also see it now at heart. There's a really big project on that. We can also see it in the skeletal system. I can actually take a look and do a digital twin of your knee if you have knee pain, and I can see what's the morphology and how it moves, and also can, with that, create different surgical procedures and test them before I even do them on you. And I can test you, like we do with automated video analysis. I can see how you walk and what we can change and what's wrong with you without even looking at you. The AI will do it. We can move that even further to something called smart arena.
And so are ways to better protect players. Powered by AWS, the NFL created a digital athlete, an injury prediction tool, by analyzing millions of data points generated by players' every move.
So we have time frame probabilities here. So I'm going to stop there. So we can actually, I can record you all. I can go to any soccer game. I can just use iPads and a little bit of other stuff, and I can see how people change their pattern, the velocity, the heart rate if they have an Apple Watch, and so on. I can see who's getting tired. I would have stopped Zlatan Ibrahimovic's injury because he was tired. Everyone knew he was tired. That's how he landed. He landed with hyperextension. He never did that in a complete game. That would have picked it up. Not a problem. You can move that down to anyone. You can be 10-year-old children or kids doing this and get the same technology that the best in the world. So we're democratizing this. But if we have that, and let's go back to the digital twin, I can talk a little bit about augmented and virtual reality. So we are seeing more and more augmented reality in surgeries, and we're getting higher and higher precision. Virtual reality, you test the surgery first, and you do that on your digital twin, and it also tells you how to do it. So it's really happening a lot about this, and I see this in the industry already. So I have 2 more slides, if that's okay with you, Professor Barnato.
Okay.
Okay. It was deep down, almost no. Thank you. Okay, I'm going to talk a little bit about multimodality reasoning. And if you look at this, this here, maybe I can show you on here. You can see it's very difficult to see, but you see there in 2022, you see USMLE, which is an open United States medical licenses exam. It's quite good exam to test you. And you see there it's like in the 40s, like 2 years ago. But MedGemini is now up in 91%. You don't get 91% unless you're the top dog of the United States. So that's the worst we do today. In 2 years, we went from 40 to 91. In 2 years, they will never be wrong. So you understand that. It's even worse than that. If you look at Amy, which is a Google one, you see there in the lower corner here, it's really interesting. What they used was cases from New England Journal, and they tested people and say, hey, will you be right in this? 30% were right, 30% of the times. This was not any ordinary physicians, the best of the best in Mass Gen. If you used Google, you went up to 40. If you used Amy, this state of the art, you went up to 50. But if we removed the physicians, it went up to 60. So with the people, it just got worse. So just solely, it was better than any top physician in the world half a year ago. What do you think it produces today? last video, which is not the last video, just going to give you one more thing. Okay, I'm in the ward, I'm sitting there, I'm lying in my bed, and there's no one there, and I'm pressing the button. I want to talk to somebody about something. Why? We have Polaris today. It's a conventional agent, which is more empathetic than any nurse in the world. It is also summary. It can order dictate with you. You can have your iPad. You can talk with it any time of the day. It can conclude anything you're doing. It actually summarizes it and sends it to the surgeon and nurse's station any day. And it can change depending on who's asking the questions. So when I'm a physician doing my rounds, why on earth am I going to talk to the nurse who hasn't even spoke to them? Polaris has been speaking to that person all the time and also looking at the biosensors and wearables and everything. Okay, Christian, when is that? Today. We have this technology today. This is not the future. The only reason why we don't use it is because you don't know about it, your lack of knowledge, and we have a regulatory system that is difficult in medicine. And we're lacking behind, and we're implementing things that was 25 years ago quite hot. But today we have unlimited possibilities. Bill Gates says quite early on, said that AI is a bottomless technology. There is nothing it won't affect. And there is no limit to what it will happen to. Okay, that's it. Sorry.
Just one question during the time. Christian جيك شاق على زمن دوام عليك بس كنت لان شو له حق بس حق كريم.
لكن أمام لهذا بنزبنا للشوال الصغيرة.
This was a milestone, breathtaking and brainstorming of Christian. Thank you. I have one question.
Sure.
As we are working now on AI, you gave up inspiration, but we have also, how to say, utmaningar, administrative challenges, but also these models we are trying to start, they are biased to the data we give. So how to model to include like people from third world, not only 2 meter long Swedish native people, but also someone who's coming from Kardiology and Torhatin in this model to make it applicable to our people as an example. Can you inspire us to how to work with both the administration and the bias data?
I'm going to try to answer that quite quickly because we're on the time limit, but we can talk later as well. Okay, so what you're bringing up is a bigger picture of the data sparsity. So data sparsity is a big problem, but it's not as big as we think actually. So if we look at the data, and if we look at computational power, which is the most important, is computational power actually. So if you look at computational power in NVIDIA, it actually went down 1 million times in cost in 10 years. And Sura, what we've learned there was that speed or computational power was the only thing that affected it, not more data. But we have a problem on specific prediction analysis. So if you do breast cancer analysis in Europe and try to apply it in Africa, it won't work because they have different genes. So the prediction models just don't work. So it's more of a garbage in, garbage out. But what happens with AI is garbage in and humongous pile of crap out. So it's really important to have local data on local people. With that, it will increase with wearables. So what we have is enormous amount of data. In the world, you have 120 zettabytes of data, increasing 20% every year, but it's only 20% that is original data. Okay, I can talk on hours on this, so I'm going to stop. Please have more questions in the breaks instead. And please, this is the possibility for us Syrians to be best in the world in something. Come to me. I work in my own medical center with the AI medical center and grab this opportunity because it's between 1 to 5, 7 years, and then we're all done and finished. But until then, it's a golden era.
Professor.
Todi, أنا دومينا كمان وزبنا كوزيو دوبينا مثل دكتور أمين نوماني كريتود هايدلبرغ من ألمانيا بشينو.
Todi. So actually, I planned and prepared my presentation in English, but after yesterday, where we heard that our language should be preserved and it is very important, I will give my best to try. If I miss some words, I will fill them up with English. Todi, Professor Boranto, Professor Samuelson. أنا ما قد مجرد شيء كعلو خانسر دوميحو إذا بوكتامينا عملية دو خانسر دوميحو وإذا بو AI كيف بيلان شيكت يا دربو إيكو جلوزن هش مدينة ومدينة وخانسر وإيكو جلوزن كلينا وداومينا. Genau. لأنه شبكة للخدعي وخانسر دوميحو يعني كلايوبلاستوما دي نجرينا وخانسر أوبيس تقريبا أكثر خانسر بيس دوميحو خزينة له كون كنا قاز ترسا جورة منيشة كون بعمره 3 شيء اشتي ويا 4 اشتي و إنا خدوثستي الكراينا اوكي كي بدوه كي ودوريشو كي بدوه neurological deficits يعني ليبن حكي ايدو يعني إيرغلو وإنا قد حزينا وخانسر دوميحو غلب صعبو يوتسيمنا تريتمنت مبادشينا بعملية بس جوزن دوه radiation وكيموثيرابي بس للأسف مقد سيمينا استي medium survival فويش حمشحسر يرحي وبصر ليبان فايش سيمينا ميديم يعني كتلان ليميت كتلان حدود احنا كفيزيشنز وموخا لازم داومينا سيمينا ريسيرش مشان وميدانو دوي كايس مستقبل قدم كراينا وخمسة دمح يعني glioblastoma is a whole brain disease لاتشو دكتور حدو وبصر خلاص هاك كمان حق حولك هايسو إنه وخانسر دوميحو كوين كتلة infiltrative expansion وموخا صعب غلبة بيعمل بس مع الكانسر موخا خدمولي بلوزن سيمينا surgery radiotherapy chemotherapy وبصر سيجن داومي كتير chemotherapy بس هاكي محوالي مقد سيد ميدينا survival لا تغلب كايسو بس محوالي موخ احنا as neurosurgeons لازم داومينا مقر مدينة استي حتى زي ما مدينة مو بامو بس مقر مدينة شطوطريا موخ يعمل يكفيش أساسية استي دو تريتمنت دو glioblastoma بس كيتو فرق مثلا و تيومر دوه دكتور كيبا مدينة غلبة شطوطر أو و تيومر دوه دكتور ليبا مدينة كل مدى قاي موخ إذا مدينة كل مدى وكاي ولا بفاش محرك إيده يا لا بفاش مشغل أو فوش بكاله إنا قايو لا بسمينا treatment هكا محولي يعني من هكا لا بنيدا كل ما يدك فوش تشيكه بو ميحا مثلا خنصرته محوي إنه غلب صعبه يو إحنا كنيوروسيرجنز دعينا من يو ميحو عادي ومن يو كانسر صعبة غالبا كشوبة الحدودي نقاطيته فرق بعينه وموخ لازم مستخدمين تولز مشان دبعينا منيو كانسر منيو ميحو طبيعي من كسيمينا intraoperative MRI يعني MRI بو بالسيرجري روم OR ومستخدمين navigational systems mapping كسيمينا ميخمي عملية وكتلان يعني درمونو شوتن ميقني عملية بصر مكوة وخانسر كوة وخا سموخهم إنا قايو كذعينا هانو خانسريو هانو ميحو طبيعي لجوز نفقين عليه بس للأسف هاني كلهش لاتنين enough we need to be better we need to improve our methods موخا احنا عضو بهالبك وتكون حاليا ستيك مستخدمينها ماشين حاثو وماشين هانو هو سبكتروسكوبية ومحوي بروتينا ألبيت دو كانسر وبصورة صورته بسيودو HE imaging يعني لا هي صورته حقيقية بس هو صورته هكذا حزيته لبس موقع شوبه HE staining وأنا قاعد استخدمينا AI موخا إحنا neurosurgeons عطنا دمينا من محوى و AI كبيرا ديركت بس 3 دقائق نتيجة من يعني كانسريو من كانسر دوي دايبلاستوما مدحرينو لو جريدز إنا قايو إحنا in the OR كيبان مدينة decision إنه أوكي إذا بوسينا أو approach تيدينا بعملية لازم دوينا aggressive موخا malignant tumor يا كيبان شيكا فيشينا دخلت موخا it's low grade genau هكذا قلت لكم شيكا أنا بقى موخا وشيولو مقا كايسو يعني كبيرا نتيجة كايسو ولا لا احنا حزينا بو تيستينج دينا انه اذا حتسوي مقارنة عمو فروزن سيكشن تقريبا عيني يوم also ده يتفرق اذا فروزن سيكشن يا او اي اي هانو عمو مشين غمان هيستولوجي اذا حزينا all cases كتلان AUC 77% بس طبعا كي تفرق بين meningiomas, glioblastoma, low grades وموقع شاتيو perfect لازم دول كايس إذا كنتنا cross table محور okay meningiomas which are good tumors benign tumors it's very good high grade tumors 9 out of 10 كايسو بس لازم دول كايس وبيضرورية احنا neurosurgeons لا تغلب بمهم ددنا او entity بس خدموا لي دعينا إذا لازم نش نداومينا بعملية ولا لا. بصير هاوي تشيك improvements حتى لو بس histological measurements بس كدعينا سدمينا molecular changes. أوكي فإحنا جابينا بنا IDH mutation غالبا مهمة وهنا غمان مشين كي بدبينا بصير 3 دقائق شو نجاوب إذا كيتو IDH mutation A ولا لا. إن خدنا كيتو IDH mutation بدنا كهذا tumor كيف نداوينا أو كيف نبغينا approach دي عملية. بس للأسف لو كل كنت IDH mutation كنت غالبا واحد موقع فوش لازم دوينا كايس. موقع بلشنا نعرضه باش نداوينا سيمنا correlation عمو MRI سيمنا اللي بعملية وعمو هيستولوجي مداومينا أوكسيميا اللي عمو غمام وهكذا محوينا الانر سيركل هو ماشين هانو غمام الميدل سيركل هو MRI والأربع كذينا إذا كيتو كونسيستنسي يعني محون عيني ماذا والعضو بس 5 cases كنا مداومينا بس حزينا كونسيستنسي إتوكو زي الأوغامان كمالان أو كيتو تيومر و MRI ستيك محوي كيتو residual tumor مش هدوينا هيش كايس ولو بس دمينا من يو تيومر من لا تيومر بلشنا على بروجكت مش هندبينا شيولوس او دعينا وتيومر دمينا كتله كيمو ريزيستنسي ولا ايه ولا لا موخا اذا كيتو كيمو ريزيستنسي دوز دمينا هيش مور اجريسيف دو سيرجري دينا موخا مدينا ندكو في غلبه مشات حفه samples navigation وسمينا single cell suspensions سمينا organoids 3D organoids مشان سمينا replica مو تيومر بولا وسمينا drug screening وعمو دايتا دو drug screening كمان سمينا combination عمو غمان مشان ندهنا بس إذا تيومر ولا تيومر لازم خدمينا عشان ندهنا و characteristics تيومر كيتو chemo resistancy إيه ولا لا لازم more aggressive or not يعني ودار بوجزء دوينا molecular guided surgery precision surgery لو بس اوكي ميلينا كل ميلة وميلة خضرينا وحلينا وبتفوش بثلا بعملية عيني يعني خلال 5 دقائق لدينا من يو molecular characteristics دوينا more aggressive approach defensive approach اي كنا ادلكوت هيش بلوز ميلينا more resection genau. موخا as an outlook كانت ثلاثة غدا بوقت لازم سمينا improve و resection استخدمنا كذا methods MRI غمان 5 آلة spectroscopy And in the future, Semina includes data do lab, drug screening, spatials, عملت tools مثل نيوبو surgery room مشان تخدش معنا عوضة طريقة AI دواء مساعدة في حالة احنا طبعا لازم فيشينا in control بس هو دواء مساعدة لدينا تسمينا surgery هيش كايس. سعودي؟
Thank you, Alan. Great lecture. I'm looking forward to talk to you later on. I'm sorry about the time constraints. And I think, in general, when we have this right now, I don't think we're going to stress, we will only destroy everyone's presentation, having a good time, but try to keep us within the 8-minute limits in the way. But just, whatever you need to do your presentation correctly, do it. But somebody needs, sorry, for what?
You should really try, once again, try to keep in time the speaker. But very important, to give to the audience time to ask questions. And that's why we are here to discuss.
Thank you for what? Yeah.
Okay, it's very important, please, to engage in discussion.
Yes, of course. And it started off with a little bit long session at the beginning, and we're trying to get that, in check, but that might not happen. So anyway, I'm going to present the new talker now. It's Fawaz Soumi. He is an orthopedic surgeon, and he's created the first Zurich orthopedic hospital in Södertälje, which is of course fantastic. We need to have this more. You're from the United States, you know all about the Jewish hospitals that are around there and other ones. So we can do it as well, and we're not worse or than anyone else. So. Dr. Fawaz Soumi, looking forward to listen to you.
I'm trying to see my...
Han kete mulso kobeina mer from dovitu amel satko u presentation lo abjad kana mai berina zabno u dositus de tutu hakke bi qameto nakana nakandakshina u zabno de khaito
Fawaz Soumi, orthopedic specialist in Södertälje. غالبا صعب على الجزء مني شلون نستخدمه لأن نقاط الرابط كي يقولوا إنه كي كفي حوزن أكون بس دكتور من ثلاثي بمو فكمية دي سفينجلسكا وخبرانه أو لاتين سفينجلسكا يعني غالبا صعبة فكي تقول أصلا إذا سفينجلسكاني بس نجنو سريو يعني أنا بدي يحكي بوسو إني شعور سليشني بس بترف وشخصة فتح لي كلينيك بسودتاليا بينانو شيء نتاع مقدرته كيتو بلكي اشتيها فو سريوي ومن فهمي عليه فهمنا عليه بس طبيعي لأن كل سريوي كيبيدي يعني تدري حمشي بوم سويدو يعني أكيد وكلينيك باتش أحسن ونوسيو جوزيف عيسى ديويلان بطراتي كوفيد وضاعرين غالبا زحمة علينا بس فايشين على الوثن بطر لا تروسي يحكم بمواقع ودينا عم كلينيكات نعيمة مسخوري كله فمقدم لنا على الميديك سلوتنبورغ يعني تكميل مستشفى انه مدمخ كيو 24 ساعات لو انت اقل بشرور دبليو بس اثري موافقه ثم الشرطات كلهم حقيقه يعني شرطات غالبا حلوين قد عودت ببروديسات احنا وترانسبلانتاقون شركي نفس الشرطاتنا يعني سمي عصروز راحت ميقف في عمليات مي هواء نافق نور زيرو بكتيريا نقاي هو اللي ونور فمي اول ديشاته اللعبه بدير ان هيب اني سيرجي بس توتال هيب ان توتال ني ريبليسمنت واللعبه سمن تقريبا وتشع عمليات ما هو ديشاته ومد مشغلنا عليه هي حقيقه هي انه لا السيده نحاتي ابن العيمه بعمره وتبعوا لي ب تسيد دو تحومي انه لازم هون كلينيك يعني لوكو بس بنستخدمه اي تكنولوجيا لوكو بعمل زينو عكس حوروني يعني بروفيسور يحكي بس مكملين حدودي سموا الدراسة على الكيو كميني مورتونز
Super.
مورتونز نيفرينوم كيو بيرغلويو كالعصر نعيمو وكنسانلي بمالخ كويولي فما حد يشمدون انه لازم استعملنا كلا غلب اذا محتينا او دياجنوز ولا كيبا بو كلينيك فحصينا ومعطينا الدياجنوز وهذا خدمه لي انه احنا فينا اسيدا فحصي وكايو لان ممكن لو تدعو للبلد كاتاستروف ليت كهرباء ليت مكسيمت لازم حتى الدياجنوز اذا لو ما حتلف بفحص لوكايو بالبدايه بترك زانو لتكنولوجيا بالاضافه هذيك محتو يقروا غلبه على مجتمعات جديدا يعني اكل دو ماجنيت ممكن دو ام ار اي كوزين موسكات كدفعين عليه مو تاكس تدفعين عليه اذا هو انه كتو اللي مو كاي يسموا لي العمليات حمشوا عملي مضارع على ان كتو مش يعني قال لي ما سلطو شوعي انه تري مني كتو اللي بطري الطرافه سيميو لي تي صعب حزين هيك أكيد سنة العمليات لا توحى أو اللي يرحو مينس يعني شلو يعني كيو ولد وزي له علاج له كونسرفيتيف تريتمنت لو ماشي له حال ينقلها وفاكرين إنه سمينا عملية ولا لا يعني لو إنه كل حد دوي قطرك سمينا العملية لا أخلاقي أبدا أكايواني تقريبا فالجيدو عمره يعني حمشي بو ميدل اولد مينالي حمشي شنيوا بس كتو مع عسري هو تقريبا لا تشعي شني زي كتوا أكايوي مخليطة بنيشي وقوري ومن المدي بي يعني مو تشخيص ما حتى بس كلينيكال يعني لو ماجنيت رنتجن ام ار اي لو ميدحرينو بس صرتو عادية بشوي يعني بس حوزينا ليتو جابي ستريس فاكتور ولا غير مسائل وبريباراتان بندوي نمي عملية مشايعي كل الكارولينسكا يونيفرسيتي فوكس دو لاب دو ثيري فحص نتيجة دو فحص فكان لي مالح انه صفر بدا في حاجة انه قرعوا كومو حزين مسائل ما يقوم روحي لا تشرونه فإن قدرت لي جواب من كارولينسكا لي بينوش دونغل والله احنا سمنا الحيلة ببو ميدانو أثيلي جواب دو تحليل بي اي دي كمحتي مقع حجم ديرك مملي عرض طول هنو كل ميدي بالتفصيل يعني لازم اثبت انه ميدان هوخه وشروله لتوا ميدي عن هيتبو يعني حوز ما كايواني 94 بمو نافيقي بالفعل مرتز نيفرينوم اثبتوا شيث بمو لو نافيقي مرتز بس مع ذلك كتولي كيوك اللي قطرك النوديول وبعوا الى عمليه هن مني ار نديولي ويني كتوا جانجليون كتوا برشي فتقريبا مو تشخيص مو بمو يعني بس كلينيكال نو يعني بس فحص توكايو مظبوط على الميكو كرخد وماجنيت رونتجن اللي تغلب المعلومات جابينا اعلن المقطع بس اثيلي ما حوروني انه لو تو تشعي بمو فوبيلق جواب مضبوط انه اذا مورتوني ولا نتيو مورتون فاي نتيجه منه انه احنا اذا فحصنا فحص مضبوط لوك ايويدا كيبا نعطينا النتيجه او على الاقل بدينا مكسيمينا كمان لا حول ليدي يعني كو ثاني كايو عمل حمش عيشني هيك تربط لي ماجنيت ام ار اي ليك ميدي يعني لا يوم ينيس دوتي والله مش عارف فوتبول ليه فمفكر ميقا ما مشيعت فحصوا كايو ومطيني نتيجه عتله وتوديره
réussion del governo un racimo un cario credo come هكا كيتو شوالو عند مالخ وعلوزة كيتو حق شوالو نوشت كوبن شاي
لو ملنوك بعنا مانو ميدا لوش بيرو إنه سمولي كيتشو تتولي تشعو بريغي وثالثة بلاك بلمينج لينان بوستيريوري كتفوا لي بدروعي حذو مامو مريضات ما نرسات دو أوسيو حزلاني وزينو ثاني بشو قلت تلي كتولي حدايت هركي قد شو رابوي سمالي بيبات كريهي ملالي مو يساقسو سيدي من بس بينات هو سيدي يعني ما قد شاتو دروعي كوي وكل جنوفر يا سقنو سوسيو ملاني يوم ما تعبنونو وما كونو بل ما دانو درو هنا مرة اللي بمو شوعي بقدرتنا قاعدة مع الدرو يا تفك درو حرادة درو يا هذا
تودي لا تشولو بس تودي له في الحونة سن نقطة بس كمان أنا كنا جاروحي عدو مدد بروفيسور صامر صامر لي احنا فيشينا لو شغله وأي سويت من مدد أبغى زي ما جراحة وسبيكر حارب وفرحانو كتيو دكتور المستمر كتيو أبرد حولي وكوسينيدي قدوبي إيمتو على كيفن دكت فوتي
Familjerna först, min föreläsning där. Går det bra?
Okej, vad fint att
اوكي سي فواز كتلي شغله او قاعد هتبدا له يعني بذكري قاميته هركي بيكم شعور سريش ناثت بيكم 28 اسم له خويلي راغلي تدروا بيقامش له بس وشو ليدي منكم بتلن ادفايس نصيحه لنا لدكاتره حاثه ناعمه مجرينا سيمينا او خطوه خدها تسم له ويدر بوتزدانو يعني بودربانو
لقنو صحيح أي حسنا لأنه لأنه لا تلخ ثقة ببوليتيكر يعني سياسيين هيك كل يوم مغير رأي ذثي لو عبرنا بالتفاصيل غلبة احنا كثولا أعقد بتشح بتمون أحصر إنه كتوتو تري دكاترة وليتو شرطات عليكم ميدي إنه كوانتيتي دا عمليات بثر شاتو أثيث الجدي كورونا ميلو احنا مغيرينها مغيروتو لازم هوتو اشتو دكاترة سبيسياليستر وحا استي ولازم سيموتوا 1800 عمليات ما يكون مطينوا شغل الاشتو ما يكون يعني كل يومكم يبادلكم يغير اثمل على مدة قرار بو محلين على ساك سخري دا دوغلدو رمحل سخر تشعوك لي نكات دقر مي صغيرني ليت ميدي ضمان انه والله فتحت وما كملت وكل ما لي كوثيلا بوليتيكا محوي انه واحد عود بيطب ببور لوكد مويد مربح ومربح من يدي لتيو ميدي يعني 4 فلقه تشعوا بمه يعني زخم زمنة بوزرع بيشوفكم بقصة موقع صحنا فوشوا بمستشفى
That was a great last comment. Anyways, as they say in Navy SEALs, improvise, adapt, and overcome. So, Yilmaz.
Thank you. Todi I work as an orthopedic surgeon in a hospital, and I did my thesis in Cardiology Institute for proximal humerus fractures and surgery with shoulder arthroplasty. Okay, so this is a very common fracture. It's the third more common fracture in the bones. So the femoral fracture is the most common, and the third more common is fracture on the shoulder. If we divide it with age and gender, we have 2 peaks. The first peak is in the younger and high energy trauma. After 50 years old, sadly enough, we get older and weaker, and we have an elevation of fractures, the incidence, and it's more common in females since they have more osteoporotic bone. And we have 3 bones in the shoulder. The first one is the clavicular. Most common treatment is non-surgical, we'll come to that. And depending on how severe the fracture is, if it's a simple two-part fracture and you don't have any biomechanical problems, you don't do any surgery, it will heal. If it's a Z-shaped fracture with a severe displacement, then there's a surgical option. If you go to the scapula, it's a more complicated bone with several parts. This part is the muscle tissue holding the shoulder in place. Then you have the joint against the upper arm. Depending on where the fracture is, we have a treatment for that also. Most common treatment is non-surgical. And then to my favorite part, the proximal humerus. And as you see, a lot of tendons is attaching to the bone to have the range of motion we have in the shoulder. And depending on the trauma and how severe the fracture is, we have several treatment options. So, two types of treatment, non-surgical and surgical. And it doesn't matter what type of treatment we choose, physiotherapy is very important because if you look at the hip, you're happy to be able to walk again. That's good. But for the shoulder, you want to go all the way. Not only do you want to walk with the shoulder, but you want to go to full split. So it's a different demand. If you start with a clavicular fracture, so if you have severe displacement, we have several plating systems depending on where on the bone the fracture is, because the clavicular has a S-shaped and three-dimensional shape. So we have to choose the plate correctly. We had a severe case where my colleague chose a flat plate, then they pressed the clavicular against the nerves going to the arm, and we had to remove it and release the nerve again to get the function back. So you really need to have a three-dimensional sense to fix those kind of fractures. This one we will not use in Danderyds Hospital. We have a level 2 trauma hospital doing most cases in Sweden, but we don't see any need for the nailing because if the fracture is not displaced, why do surgery? You can also do the surgery of the scapula. Most common fractures are actually in the body and you do not have to do the plating. We do the plating of the scapula if you have dislocation and instability in the shoulder. If you go to the proximal humerus fracture, where we have the most common operations, we have several types. So it's a complex fracture where you can put everything back together. We use plating and screws. If we have a two-part fracture, we have the option for nailing. If you have cuff type fractures, we can suture back the tubercles, we do that. And for the patient that we cannot fix, we can change the joint with a shoulder arthroplasty. The recent years we use the reverse shoulder arthroplasty, where we switch the balance in the shoulder, put the ball in the scapula and the socket in the humerus. This was previously more used, and this one is actually more challenging than that one. It looks more complex, but this demands more surgical skills. So in my thesis, I made an algorithm. So we have the proximal humerus fractures, and 80% are treated non-surgical. Why do surgery when the result is as bad or good with surgery? Anyway, if you choose surgery because it's a complex fracture, you have two aims. One is aim to minimize loss of function. You see that it is a young patient with high functional demands. You have to decide, is anatomy possible to restore? Okay? Then within 24 hours you should do surgery, but with our system we seldom have that opportunity. Then you fixate the fracture. If you do not see that it is possible to restore anatomy and you retain the cuff intact, you can choose an anatomical prosthesis, or else you choose a reverse prosthesis. If the indication is pain management in an elderly, sick person, that you have to decide, should I do the surgery? you have the time on your side. There is no time limit. The results will be the same. You can wait, you can see, you can wait for 4 to 6 weeks. If the patient does not have any pain, why do the surgery? If the result is the same after 6 weeks. So we usually wait 4 to 6 weeks. We optimize the patient and see what demands does the patient have. Then we can do the surgery later. With non-surgical treatment, there is also risks, of course, and we can do surgery later. One is that the fracture does not heal. The other one is the circulation is damaged and the bone dies. Then we can do the surgery also. With surgical treatment, we have the same problems, but with infection. If you open the skin, you have the risk for infection. With the reverse shoulder arthroplasty, there's a risk for dislocation. And if we fixate the fracture, there's a risk for non-union also. Then we can deal with that later also. Pain is a problem, and with the plate osteosynthesis and that kind of open reduction in terms of fixation, we have avascular necrosis, and range of motion is a problem. You get stiff in the shoulder without surgery and with surgery. Thank you.
شوالو اكيد هو شلون كلكم تودي سيو تودي بروفيسور طبعا كليا شوالو لو بروفيسور هذا كليا شوالو لو دكتور فلوس نورو سيرجري بس دكتور يعني اسوي اكثر جيلت علو كيف نجوي نسريو ولا جيلت علي كاتفو على عمليه سميسون بيبي كاتفو كيتو كيو غلبي يذيعوا هي امبينجمنت سيندروم من كوسيموت هكي بسويت كوسيموت لاندوسكوبي ولا كوسيموت لاوبن يعني جراحه فتحته ومن النتائج وقابل احنا صراحه لا تنقل على كودوري وكايو كودورا كويولي كودوري نفس سيمبتوم ولا من هكي بسويت من كوسيموت ومن نتيجه بروجنوز ريزلت وتودي ساكي
تودي شو لايدو impingement اما يدكسو كوي عطا هكي كوي التهاب اوكي اما كوي التهاب حق شعر قيها بالتهاب موقع وكايوانو بزيودو بلياتو فوضو لكشم حركة وكل كلبنا ريجي وكوي يقرأ على كتفه حمك شويم حق لازم مضعر قشمة الدكفة قعود عمو شقونو وطيزو وحاسو مساورو وكتفه إما مساورو وكتفه معناته الدكفة نطلب التهاب ناقص إما ناقص التهاب أزيو كيبو ميركم حقق لي هيتشمك كلوز بود تمري هذا وش مكوله هو خيو يعني احنا دوينا سوي يا إيكاش ذا هوخا يا ذا هوخا بس أود أعطي إمبينشمنت وحزة أزل الفيزيوثيرابي ولا ما فعله حكيبه معهد كورتيزون معهد التهاب داون فيزيوثيرابي هذا اللي ما فعله حق زي عملية كسينا لك اندوسكوبي نطلع منطقة التهاب كميلة هرتشاي مو قرمو هانو ومفقد دكتور هيش قلت لك سمي فيزيوثيرابي يقدر كايس الكو كايس ايش البانو كون كايس بس هانو وكتفو لازم روبش غلبة يعني بوسو بوثو كوعي بوثو وكنوشفو كتفو يعني هانو عمره كوثي يعني ليك شارع يعني ترغو يلسو بوثو نطلعو بودك محمنا كيوي هو خمسايل بحارتو إذا دوي أرتروس سيوفو نقلعها تمعت بروتياس إذا وارد مقطوعي يعني حيث شخص بين إشتي حمشوشتي عصر بمو كنت قطوعه دواري دو لا تهاش سمت أمراي بين إشتي الحمشوشتي كنت عصر بمو كنت قطوعه دواري دو لا تهاش impingement بين مو إشني بعد السيستم للسيمو اللي يعمل عملية له عملية هيش لا يوم اللي كنا عم كسيمينا بس مفتكرين موظفينا تشيك هوخا بعد صرنا زوزة صرنا عملية الكلية تشعر مبو دوم كارثة من صنو عصر بمو ملكون كارثة موقع كتو بين لو بثكي هذا بس بين ذوق البيروت دكتور دواء كتفو كيو كتفو شبثو كي بدنا ارتروسكوبي بارويو ليش خسارة بوي وكنت زمنو دي عملية كلوزم ليانو ليه هاوي عملية الكلوزم شكرا موافق الشيء
سنعمل مختصرا section orthopedic and behavioral surgery تودي غالبا شامليته ان شاء الله فاهمينكم ماذا عليها وتودي بروفيسور توم ويلسون يكون مانجمنت انا
تودي انا شاب وين دوم برلين ماكلينا كل ميدي introductions كل ميدي ماكلينا نتاقنا مقايزين وقتنا ديسا غالبا في حيون ونشرو برمانو بو كارديولوجي كو شغل مي يون كوبينج كوسوم هي زي ساينس كتلي اوريجينال بابليكيشنز او دوك كرخلي علي publication history دي كوسوم publication بو لانسيت سملي غالبا في حيونو دو بينو خبريلو تودي لا خبريلو
تودي غالبا سمعيتوا لي؟
الميكروفون هذا
عاوزين ايضا بمفتحان
أنا أوكي. السلام عليكم. عم بيقرأ إنه شمي نشرو برمانو إنه أسيو دوليبونا و interventional cardiologist نو يعني كيف وشغلتي افتحوا الدواء للدوليبو يوم. عودنا بديته إشمع يونشبين تقريبا 13 ماركة. قد مجربنا عنده إنه استيجران يتسمى بسوريا وقد محكينا الخو على كيفو دواري ذا دوليبو وبطر بحاري توستيك محكينا تشيكي على كثيريو ذا فرسلان بانشنا حوالي وكيو دواري ذا دوليبو وسببها مويو لموتو بريثو كولا يوم والتي بس سبب الموتو سبب لكيو يوستي يعني disability وحوزيتو بخارطاته كيف غلب فرقونو ومن يونا مقرابو يتكتب كيوانو ببريثو كولا وليبو كتلة تري واردة وسيمولو ويامينو وسيمولو خايفوك مفلغ لتري فرعي موقع كي بدمر يعني كتلة ثلاثة فرعي مهم بواردو وسبب نورمال لوكي هو دواردة دوليبو وأثيروسكليروتيك بروسيسيون وينقد مملي كالشو دهنيثو دمينا كوليسترول قاو دواردو وواردو كوعيقو ونقدو يعيقو وقت مولي بفو يدخل عادة بضمار بواردو ونقايو برشاي موليبو كي بدمويث وكيوانو كي بمحوي بشكلات فريشة حكي بدوالي chronic coronary syndromes يعني stable angina إنقا حد كويو للصدر بس إنقا حد سوي ميدي يقورو بشمانويو وحكي بدوالي acute coronary syndromes إنقا يعني نقا حد كيو للصدر والصدر إذا هو ونورمال myocardial infarction يو وإحنا كفلغينا بين non ST elevation myocardial infarction أو ST elevation myocardial infarction وmyocardial infarction وسبب ديده هو بلاك يعني إدكتو كتيو عقدو دكيتو كالشو ودهنيثو وسيو غير كي بدوي رافعه وإنك وسيو بدوي رافعه كي بمجرح إنك مجرح نقايو وأدمو كومنوشف وإنك نوشف بنقحذو كي بنوشف وبنقحذو وضمر كولة كي بمصغر ونقايو يعني برشاي مليبو كي بمويث ونقايو تهلكايو يعني وكي مليبو كي بكولة هانو إكزامبل يوم حامل بيشنز دي كتولي هانو ECG يو كتو حمشي اشتيشنو كمانو كايو صدره تلفن له أمبولانس آتي مدى ECG وهو نورمال إنك حد حوزه ECG دوي يعني شريطه مسويه إنه حتى لكن أحيانا هركي دوي شريطه مسويه هركي حوزيته وشريطه خد ياسق لفلالعل هانو استي elevation يو هانو إشارة يو د ودمر بنقح دو كالي بنقح دو أوقع باسيانتراني بنقح دو حقاز وشادر اللوكال فلاب تامد احنا قعودنا international cardiologist قعبرينا يا بو دروما بدمر دو دروما ياس بدمر درابلو وقد شاكينا خد خرطوم قعبرينا له واللولي وقد محدينا له وقعبرينا كونتراست جاو دو دمار وبو اكس راي برنتجن حايرين على الدمار من بروبلم كيت وبيشنتانو خد حوزيتو هانو وخرطوم تامو للغليو و هانو نقاحيتو وكونتراست نقاق مع بانو اللي هو لاتيو تام كاليو دمار بس خد حوزيتو هركي هانو ودمارو يامينو يو هركي كيتو لكي حرتو هانو يابلاكيو ياستي ادمونا شيفويو ونقايو معبرينا خد حوطو دو حديد قاودو دمار و علمو حوطة وبطرق معبرينا بالون ياست ستنتس وقد جاربينا تفتحينا يدكتور كتي عقدو ولجان وادمون نقاحرتو تخوي لو بروبلم كنت حوزينا هكي وهيدو إلى كايو هزام حتى السن وعندو وقدمو لو بروبلم كي خوي بيعود الضمان ومادة مستعملينها وشغل أيضا كي غالبا يعني شغل بماتريال كتلا بالونس وستنتس بس كتلا بالونس كتلا خد جليتات عليه كتلان بالونات كت سونار كتلان بيرز بور مقبو لجن فتحينا أوارده يعني كت غالبا المسائل حكينا بستعمل هانو تشيكي على يعني على interventional cardiologist دا وارده يو وعودو قد محكينا تشيكي على حامة كثير فرس هولان هانو لانست هيرتي لومينيتي هو إنا قداتيو كورونا لا رأينا وأيدر بو قد مأثر كورونا على كي ودولي بو دواري قد يوسقو قد يوزد نوشع قد يوثنو أو مقدويو حرلان ألومنيونو قايث myocardial infarction بوزابنا دي كورونا وقايسلان عمنش ندماغم ومدد حزيلا ومن يونو غالب ناحت وديلونويث أنيشة كتوية شعيشنا أو زد همم فليغ ومن يوناثي خايو لكرينا تمام بس لازم دوث البولينا هركي بسويد لا تولا لوك داون خد غالبا ما دول حرينة هركي كتولا يحكومي مرلا ديلانويث لو عمل كتير شعيشنا أو زد فوشو بيتو لزقو حوزيتا نوشي وبلكي موقع وميدانة حوزينا وقايد زد نيشة ما قوري حوست لكذعينا بس كذعينا النيشة نقاطة مايكرال انفاركشن لا تيكون قد كتا عيني سيمبتومز قد قوري وكميناس بلكي النيشة زد ما قوري لكبعي دون تعبو كذعي وكيتو غالب تعبو بثريهم موقع بكي أخرى وزننا إن اليوم أوكي ما قالك محكينا الخوال كثيرا تحريت تسمونا هو ينقد ودمر ينقد هو تام صغير يا تام فتيحه لا تصعب كلنا كحوزين عيني منه بس ينقد هو دمينا حمشي فرقت صغيرة كذا عينا ما ستاديس ما كبيرة عيني صرت دوبينا اللي تخيط فريشة حق دمر 40% تصغيره حق دمر 70% تصغيره يعني غالبا فالسفوريد حق خوير على صورته أيضا حق قتل objective evaluation نحن نسميها physiological evaluation بماكلينا وتنسيون جودة دمان ماكلينا وتنسيون نقم وبثر ميدكتر كتير شيء سخرتهم ماكلينا أنا حوزينا خد بس دمينا كيت برشات طعمه تشيكي صغيرة طعمه تشيكي معبرينا واير خطوطه هركي ماكل تنسيون هركي وبطل كتلان ببداية بضد مرسلين ماكلينا وحوزينا إذا كيت فرق غالبة يعني نقايا هانو مهمة وقالوا سيمينا مادة وكيت وشكل عاتيبو إنك تسيمينا ماكلينا وكوبينا هرمونو سويمولي بتشغل حيصو وكم آثر شيء على الباسيات حكيا ولا شيء نفس صعب يحتقرش نفس وهو موقع بنشنا حروية حبدالة سويم حد ماكل لو مضرمونانو واحنا وبليثا كلها هن مستعملي وشكل اعتقاد كتير جولدن ستاندرد وهن مستعملي وشكل حاثو واحنا مقايس لنتري هلا ايدر بوي زيلان 80% عيني مادك محمد بس 10% اللي محوي عيني مادك وديناريث بو والدو يعملوا وياك عم نستعمل هايبريد ابروتش يعني حد بودي عم وهذا لود مدرمونو وياك عدوي بس بجري زون نقايو حدو بمدرمونو نقايو 50% من patients لجلوزم تقاثر مدرمونو وهانو كمان نقاي يسرطو حالي دوا أنا قال شو
توديسيو بس شو لو خكريو بوكا هكا بو كورونا بو ارتريس سكليروز دا وارد دوليبو مرق محتي ستند كمو ستند كو محتي ميقم نفكر انه تسمي اوبريشن ميقم نفكر انه تسمي عمليه يعني كمو ستند حكي بماحد وبثر لو كي بماحد كلوز مناقه حسن عمليه دوليبو توديساك عمليه يعني
اوبن سيرجري يعني شو لو اما حكسوم اوبن سيرجري اما حكسوم ستنتس وهذا لاتيو يعني حكون لك بود ام ستنتس وبطل حكسوم اوبن سيرجري هو كيت فاكتورز دوني كمي لازم سيم سيرجري وكيت دوني تسمي كمي لي سيم سيرجري دمينا و patient دو غالبا بعمره لويو كيت high surgical risk هانو حسب بيو تكون آثر أين من الميثود المستعملينها مثلا هو anatomical complexity وستند دو بلاك ها وأدم بس ها دمر في طيو هرايو تفتحين الدمر ما حدين استند بس إذا دو ببداية دو واردو سيمولو دمينا وإذا دو أثلث وارده ودو غالب بلاك ياريخه نقايو it favors cabbage, it favors bypass. So let you يعني بخامة تقدم stents وبطلق سينا surgery. حاليا على صورته نقدو patient factors, anatomical factors, different factors influencing which method we are using يعني يا bypass أو يا PCI. وكتلان heart team discussion. سيمينا discussion I'm a surgeon, normal cardiologist, interventional cardiologist و قررنا أين مثل المستعمل. ما تبينا شو ولا حرينا
لو كثير كايوي غالبي كمي كتلن سيمتوم بس لو محوي لميدي لو بو ايكوجي لو بو ام ار اي لو داتا ومن تسمي لك محوي بحياتك زين جبريوس يسمى حوزن كي جابي قتلوا رابو من تحت لسن نقاط سميله هي بفتيحه يعني من يو
أنا شو لو غلب الرابو يوم وكل معين تسمينا لاتيو بمو مو يعني 100% كيت specificity و sensitivity يعني ومادة بسوي وما يقوموا نورمال exercise test يوم وكذا عم ببدأ exercise test لاتيو معينة كايستوت حتحوزن إذا كيت واردة عيقة أعدو بنشنا حروي زد كسيمينا non-invasive coronary angiograms يعني computer tomography نقايا كيما حوزينا بطركيت معينات حرينة كوثن سكين تجرافي وبشكلات حرينة وبطركيت هش كيت هاني قاتك كيو تصدره بس لت دكتور عيقة كيت microvascular disease as well يعني شو ولا ولا برافو
Honorable Deno Bijahaliyevi, I'm going to switch to English. I was positively enlightened by the talk about the artificial intelligence, but also left slightly depressed. And we will see what this has to do with my talk. By the way, the talk is completely scalable. I can stop at any slide. If the organizers of the meeting want to, just lift your hand and hopefully it's still going to be fun. Also talking after spine surgeons and cardiologists and neuro-oncologists, you also are left a little bit depressed because I'm just a nephrologist. We are in the field of internal medicine. We don't do interventions or big surgery, or even microscopic surgery, which is probably even bigger. But still, we are dealing with very sick patients. And when you look at this slide here, this is a big publication which looks at the complexity of patients in internal medicine. And you see that in many, many regards, nephrologic patients, patients with kidney diseases, are the most complex ones. They have the most comorbidities, they have a very high risk of mental health deterioration, and they have the highest number of prescribed medications. And in the overall rank, they are the most complex patients. So this is what we deal with every day. And you need a doctor like that, you probably all know him. He's a nephrologist, he's a genuine nephrologist and intensivist. So this is what you need. Maybe in the future, you will need artificial intelligence. And I learned today that adding a doctor to decision-making in diagnostic procedures makes the result worse. So we're going to have difficulties in the future. Maybe it's bright future, I don't know. But at the moment, we're dealing with this year, and you need bright nephrologists to deal with this complexity of our patients. And now going to CKD, CKG is a major global public health issue. Most of the people, we have Fuad here, he thinks cancer is the biggest problem, and we have cardiologists here, and cardiologists always say most patients die of cardiovascular disease, which is both true. But CKD is a very, very big health issue. CKD affects 1 in 10 adults. This is 850 million people worldwide. Patients with CKD have a very, very high excess mortality, and it leads to increased hospitalizations and to utilization of healthcare resources. And the most common problem is the cause of CKD is diabetes and hypertension. These are all diseases of our civilization. And the problem is not going to get better. This year is a projection from 2016 to 2040, and you see the value of chronic kidney disease in mortality, or this is a statistic looking at the lives lost, yearly lives lost, and you see that the rank of the chronic kidney disease is rising to number 5 on all diseases that we have. So this is a very, very big problem that we have here with CKD. And we know that about 40% of the reasons, the causes of dialysis-dependent kidney disease is diabetes, and 30% is high blood pressure, and the rest is about 1/4. So these are our problems: high blood pressure and diabetes. And this is the scale that we look at CKD. This is a very, very important slide. We look at our GFR, which is derived from the creatinine values here. We have a GFR which is normal, more than 90 milliliters per minute, and we have the patients who go on dialysis with a GFR of less than 15 milliliters per minute. And if you want to have one take-home message for today, we don't only look at the GFR, but we also look at albuminuria, which is a very, very important risk factor for cardiovascular disease and mortality. So that's an important slide. But in the past, we didn't have many medications. There was just one. These are the RAS inhibitors, the renin-angiotensin-aldosterone inhibitors, which affected that problem, which were able to slow progression of kidney disease. And now in the last decade, we have a few more, and in the next decade, we will even have more developments affecting that. And if you only look at the left part of the slide,
look at the 30-year range. Let's say you are 30 years old, then you have on average a more than 40 years life expectancy when you don't have CKD. But if you have CKD, depending on the stage, you see if you are 30 years old and you have a CKD stage 5, you only have 12 years left. So it reduces your life expectancy from 40 years to 12 years. This is a very, very big difference in life expectancy, and you have the same value C for albuminuria. So if you have albuminuria, your life expectancy decreases manifold. Now, coming to the topic of my talk, this is fluorescein. I'm going to talk about fluorescein, and this is Joseph von Mering, who lived from 1849 to 1908, and he was doing experiments on dogs. And he induced diabetes in dogs, and he looked at the phenotype of the dogs, and the dogs developed glucosuria. He measured the glucose in the urine, and they developed thirst because they were drinking all the time, and they developed weight loss. And then, a couple of years later, he used a drug derived from the bark of the apple tree, and this was the fluorescein. And when he gave the fluorescein to the dogs, this led to glucosuria, it led to thirst, and it led to polyuria and weight loss. So these dogs have the same phenotype as diabetic dogs, but they didn't have diabetes. And he didn't know what the reason for that was. And now this here is fluorescein over there on the left upper corner, and here you see drugs that are developed and in use today in all parts of the world. The main drugs are empagliflozin and dapagliflozin, which are derivatives of the fluorescein that we know since Joseph von Mering did his experiments on dogs. And where do these drugs work? We know they work mainly in the cortex of the kidney, they work mainly in the proximal tubule, and they block a transporter, which is the SGLT2, the sodium glucose transporter 2, which mediates the uptake of glucose in the proximal tubule so that we don't lose glucose if we're not diabetic. We all who are not diabetic have zero glucose in our urine. But if you interfere with that transporter, we lose glucose in the urine. This is what happens, and the mechanism for this SGLT2 transporter was discovered in 1960 or 1959 by Robert Crane, and famously he wrote the mechanism of that SGLT2 inhibitor on a napkin, and this here is how it works. We have the sodium glucose transporter on the luminal side of the nephron, and it transports one sodium and one glucose into the proximal tubule, and it gets reabsorbed. This is how these drugs work. And then, when you go a little bit more in detail, they have secondary effects. And one secondary effect is that it can, with this uptake of sodium and glucose, it can affect the vasoconstriction and vasodilatation of the vas afferens and vas efferents of the kidney. So it can mediate the pressure in the glomerulum, and it can mediate the filtration pressure in the glomerulum, and thereby the renal function. So this is what these drugs can do. And what we know is that in diabetic patients and the patients with diabetes and CKD, we have a high pressure in the glomerulum, which in short term leads to a higher filtration and a higher GFR. You could say, whoa, that is very good. We have a very good renal function because the GFR is high. But on long term, in 10 and 20 years, this high pressure in the glomerulum, this hyperfiltration, leads to sclerosis and fibrosis. And we have CKD and progression of kidney disease. So if we could interfere with these vas afferents and efferents leading into the glomerulum and out of the glomerulum, if we can lower the pressure in the glomerulum, then we could relieve the pressure in the kidneys of this blood pressure in the glomerulum, and on short term have lower GFR, but on long term we preserve the kidney function. And this is what these drugs can do. And this here is one type of drug. This is canagliflozin, and you see exactly what I described. On short term, they have a lower GFR. You have a dip in you have a decline in the GFR. But on long term, you have a stabilization of the GFR. And all the drugs of all classes and all pharma companies do the same. And this here is when you look at that, you have a decline of the GFR of 70 milliliters per minute in 3.5 years with canagliflozin, but in the placebo group you have a decline in the kidney function of 15 ml per minute. So this is what these drugs can do. If you project that to 12 or 13 years, you have a time won without dialysis of more than 10 years, 12.5 years. So we have one type of drug which slows progression of kidney disease and relieves our patients of this high burden and complexity. Now, what is the time? It's finished. I'm going to skip the next two drugs and come to the last slide. We have, at the moment, we have 3 drugs which are able to slow progression of kidney disease. SGLT2 inhibitors are one type of drug. We have our GLP-1 agonists and all the incretins that we have. There are many types of those. Maybe mostly known because you can lose weight with them. This is the semaglutide, the Wegovy, or the Ozempic, as you all know it. But we know with this loss of weight and with other effects of those drugs, we can stop progression of kidney disease. And the third type of drug is we have mineralocorticoid receptors. We know that the mineralocorticoids with the effect of the receptor lead to inflammation, fibrosis, and sclerosis. And we have new inhibitors of these mineralocorticoid receptors which interfere with all these processes and can slow progression of kidney disease. And this here is the next to last slide. These are the 2024 guidelines for treatment of CKD, and we have these three new classes of drugs which can slow progression of kidney disease. The SGLT2 inhibitors that I talked about. We have, especially in patients who have hyperglycemia and diabetes, the incretin mimetics, the GLP-1 agonists, and we have the non-steroidal mineralocorticoid antagonists, which can slow progression of kidney disease. And this here is the last slide. What you can see with all these, mainly with the SGLT2 inhibitors and with the GLP-1 agonists, these are all diseases of our civilization. These are all diseases of our lifestyle that we have. We are mainly overweight, we have diabetes and hypertension. So we are developing drugs to slow progression of kidney disease and progression of coronary artery disease and especially heart failure. This is the main effect of all those drugs, reducing of hospitalization and cardiovascular death. But these are all lifestyle diseases. So this would be one thing that we could do to reduce the comorbidities and of course reduce the amount of drugs that we have to take to improve our life expectancy again. Thank you so much.
حوجي غلبة هركة مخلصينا وردو كتلة أفتو بس كوبانو دعينا بس charity وأفتو a quarter of break. We will gather her at 11:30. بعدين أنا قاعد وهكذا ما كيتو شوتيتي وقهوة منطقة وعمي وهكذا قدرين الشوتي هودي.
شابو بينا depression pills.
لازم.
مفرجنا يقرأ وحده وفلقو قامويو داترقومي تايم وعدو كيتو أفتو معدو الروعو مدينة قحرة تكتوينا عميخو قفرسينا ماركي مو إنستيتوت كارولينسكا بستوكولم أترقوميت قدوثن فوشو عمينا تحقيب واسيريا تبي فلاغو أتحرسيوثي بو تويتر كيتو بو فيسبوك كيتو بو يوتيوب كيتو ويومو كولي هركي قفرسينا وعصرية بدعرينا الخو نقحرتو بيقالا بس معدو الروعو قد بودن أترقو محريني